we can move to the third mechanism of antimicrobial drugs. This is drugs acting by inhibition of metabolism. And the most important metabolism related to microorganisms is folic acid metabolism. First of all, we will discuss how folic acid is synthesized. So, three substances: pyridine, para-amino-benzoic acid, and glutamate. These three substances combine together to form dihydrofolic acid. Dihydrofolic acid is simply named as folic acid. It is dihydrofolic acid. The enzyme involved is folic acid synthase. This is the same folic acid which we take in diet, dihydrofolic acid. But dihydrofolic acid is inactive. Its active metabolite is tetrahydrofolic acid. Tetrahydrofolic acid. Tetrahydrofolic acid is also called folinic acid. So folic acid is converted to folinic acid. Dihydrofolic acid is converted to tetrahydrofolic acid, and the enzyme involved is dihydrofolic acid reductase. Tetrahydrofolic acid is active component, so this help in formation of DNA. So pyridine, PABA and glutamate combine together to form dihydrofolic acid. Dihydrofolic acid is converted to active form tetrahydrofolic acid, which help in formation of DNA. Now dihydrofolic acid is taken in diet, whereas tetrahydrofolic acid is active component of folic acid. If we inhibit this pathway, DNA cannot be synthesized. And if DNA is not synthesized, bacteria will not be able to grow. And the options we have are: number one, we have a drug which can inhibit the folic acid synthase enzyme. Number two, we can inhibit the dihydrofolic acid reductase enzyme. The drug inhibiting the first enzyme, that means folic acid synthase inhibitor, the drugs are sulfonamides. Sulfonamides. Whereas drugs inhibiting the second enzyme are trimethoprim and pyrimethamine. Now, special thing to remember, if we give only sulfonamides, they are bacteriostatic. If we give only trimethoprim or pyrimethamine, they are also bacteriostatic. But if we combine the two, the combination is bactericidal. Individually, both are static, but the combination is bactericidal. So we'll discuss these drugs one by one, starting from sulfonamides. Sulfonamides, they are also called sulfa drugs because the name of most of these start with sulfa. The examples of sulfonamides are sulfadoxin, sulfacytine, sulfasoxazole, sulfamethoxazole, sulfasalazine, sulfadiazine, and one sulfonamide whose name do not start with sulfa but very important, it is dapsone. Dapsone. Sulfonamides are structural analog of PABA, means their chemical structure is similar to PABA. So that means they are competitive inhibitors of folic acid synthase enzyme. They, instead of PABA, they get incorporated in the folic acid. So folic acid is not produced. Now, important to remember, in pus there is plenty of PABA present. Pus contains lot of PABA. So that means if we give sulfonamides and the area contains pus, then sulfonamides are less likely to be effective because already lot of PABA is present. So in the competition, PABA may win and folic acid may be produced. So sulfonamides are ineffective in the presence of pus. Okay. Now first of all, general points about sulfonamides to remember. Their names start with sulfa. They are called sulfa drugs, and sulfa drugs are very important regarding their potential to cause allergy. So that is called sulfa allergy. So when we give sulfonamides, the person may develop allergy, and when a person develops allergy, there will be rash on the skin. And if we want to remember important points of sulfonamides, we must remember the ABC of rash. They are causing rash, sulfa drugs. So we must know the ABC of rash. A stand for aplastic anemia. Sulfonamides can lead to anemia, leukopenia and thrombocytopenia combined together called aplastic anemia. Then B stand for bilirubin displacement. Sulfonamides can displace bilirubin from plasma protein binding sites. Like this is blood, this is our brain, which is bounded by a blood-brain barrier. Normally in the blood, the bilirubin which is present, this blue is green is bilirubin. Bilirubin which is present, it binds to remain bound to albumin. It is not free. So bilirubin is bound to albumin. As we discussed in general pharmacology, this bound molecule cannot cross the membrane because it behaves like a large molecule. So when we give sulfonamides, sulfonamide also tend to bind to albumin. So sulfonamide also try to bind to albumin, and when sulfonamide bind to albumin, the bilirubin becomes free. This is called displacement. So sulfonamide displace bilirubin from plasma protein binding site. Now this free bilirubin, it will tend to enter the brain, but it cannot enter the brain because it cannot cross the blood-brain barrier. So even if the bilirubin become free, it does not cause major harm. But the major harm can occur if there is absence of blood-brain barrier. And blood-brain barrier is absent in newborn babies. So if we give sulfonamide in a newborn baby, it will displace bilirubin which can enter the brain, and then it can deposit in basal ganglia. And deposition of bilirubin in basal ganglia of brain is called kernicterus. So sulfonamides should not be given to newborn babies because of risk of development of kernicterus. So B for bilirubin. Sulfonamides can displace bilirubin which can result in kernicterus in newborn babies. Then C for crystalluria. Sulfonamides are insoluble in the acidic urine. So when they are filtered by the glomerulus, they come in the tubules, they get precipitated. That is called crystalluria. If the crystals are big enough, they can lead to obstruction, which can even lead to renal failure. So crystalluria can lead to renal failure. So very important precaution is whenever we give sulfonamide to any person is instructed to consume large amount of water so that they become diluted and do not get precipitated. Now MCQ asked is which sulfonamide has minimum risk of causing crystalluria. So obviously the drug which has maximum solubility will have minimum risk of crystalluria, and that you can remember sulfasoxazole, the name says SO means soluble. So most soluble sulfonamide is sulfasoxazole, so it has minimum risk of causing crystalluria. Then R stand for rash. Sulfonamide can cause skin rash. They can even lead to Steven-Johnson syndrome. Sulfonamides are metabolized by acetylation, which is important regarding pharmacogenetic variations. We have slow and fast acetylators. Sulfonamides can cause SLE. Do you remember how to remember these two things, acetylation and SLE? Which drugs are metabolized by acetylation and SLE? Yes, we remember them as ship drugs. The drugs which are metabolized by acetylation and the drugs which can cause SLE, these are sulfonamides, hydralazine, isoniazid and procainamide. Then lastly, sulfonamides, they can cause hemolysis. In which patients? Yes, in patients with glucose 6-phosphate dehydrogenase deficiency. Sulfonamides can cause hemolysis in patients who have deficiency of G6PD. Now, special point regarding the individual sulfonamides. Sulfadoxine is the longest acting sulfonamide, whereas sulfacytine is the shortest acting sulfonamide. Sulfasoxazole, we already discussed, is most soluble sulfonamide, so minimum risk of crystalluria. Sulfasalazine, 2 points to remember. One, sulfasalazine is a prodrug. Sulfasalazine is a prodrug. Second, sulfasalazine has two very important uses. One, sulfasalazine is used for ulcerative colitis. In fact, it is a drug of choice for ulcerative colitis. And second, sulfasalazine is used in rheumatoid arthritis as a disease modifying agent. Ulcerative colitis and rheumatoid arthritis. Next is sulfadiazine. One particular salt of sulfadiazine called as silver sulfadiazine. It is used for burn dressings. Silver sulfadiazine is used for burn dressings. Lastly, dapsone, we already know. Dapsone is used mainly for leprosy. But second important use of dapsone you must remember. Dapsone is drug of choice for a skin condition called as dermatitis herpetiformis. Dermatitis herpetiformis. So these are the important points regarding the sulfonamide group of drugs. Now, second thing we need to know is the combinations. Remember, dihydrofolic acid reductase inhibitors are not used alone. They are always used in combination with sulfonamides. And this combination is a Seidel combination. So the first combination we are going to discuss is called cotrimoxazole. Cotrimoxazole is a combination of trimethoprim, with sulfamethoxazole. Combination of trimethoprim with sulfamethoxazole is called cotrimoxazole. The name is kept like CO stand for combination. It's a combination of trim means trimethoprim, with oxazole. Oxazole means sulfamethoxazole. So cotrimoxazole, combination of trimethoprim with sulfamethoxazole. The ratio of trimethoprim to sulfamethoxazole for best bactericidal activity is found to be 1:20. If we give in this ratio, then we get the best bactericidal activity. So we developed a tablet containing them in ratio 1:20, and when we measured in the blood, the ratio changed. It became 1:80. The reason is these two drugs have different pharmacokinetics. So we want 1:20 ratio in the blood. So we changed the ratio in the tablet to get the ratio which we wanted in the blood. So we make a tablet which contains them in a ratio of 1:5. So remember, the ratio we want in the body is 1:20. But for that, in the tablet we give them in a ratio of 1:5. In the market, the tablet is present which contains 480 milligram of sulfamethoxazole. Out of this, 80 milligram is trimethoprim and 400 milligram is sulfamethoxazole. So it make a ratio of 1:5. And when we give it to humans, in the body we get a ratio of 1:20. So read the question very carefully. In which place they are asking the ratio? If they are asking the ratio in tablet, it is 1:5. If they are asking the ratio in the blood or for best bactericidal ratio, it is 1:20. But another thing to remember, which is 1, which is 20, or which is 1, which is 5. So you can remember the drug with longer name is more. Sulfamethoxazole is a longer name. So 5 or 20 will be sulfamethoxazole. And even more easy to remember, sulfamethoxazole start with S and S look like 5. So 5 will be sulfamethoxazole. Now cotrimoxazole, it is drug of choice for two important infections. One, it is drug of choice for pneumocystis xerovecii pneumoniae. Previously this was called as pneumocystis carni. Cotrimoxazole is drug of choice. Second, it is also drug of choice for nocardia. And third, it is recently found, it is drug of choice for Burkholderia specia. So cotrimoxazole is a drug of choice for Punjab National Bank. So 3 infections: pneumocystis, nocardia and Burkholderia specia. So this is important about the first combination of trimethoprim with sulfamethoxazole. Now moving to second combination, it's a combination of sulfadoxin with pyrimethamine. This has not been given any specific name like cotrimoxazole. This is simply a combination of sulfadoxin with pyrimethamine, and you can remember easily it contains pyrimethamine which start with P. So this combination is mainly used for parasites. In particular, it is used for malaria and toxoplasma. So this is about the third mechanism of antimicrobial drugs inhibiting the metabolism. Next method of inhibiting the growth of microorganism is to attack the DNA of the microorganism. And the most important drugs which work on DNA are DNA gyrase inhibitors. First of all, we need to know what DNA gyrase do. Now this is a double stranded DNA. And we know that the replication occurs only on straight ends of this DNA. So replication can proceed till this point. So at this point the replication will stop because the curved end has started. Now to continue the replication, this DNA behave like a rope. So we will hold the upper end and we will stretch the lower end. So when we hold it from above and stretch the lower end, what will happen is this lower end will become straight, but what will happen to upper end? Yes, it will be supercoiled. So DNA will become like this. Like this. So now we can continue the replication till this point. But again the replication will stop because the curved end has started. And now we cannot stretch this DNA also because it already becomes supercoiled. So to continue the replication now, the DNA gyrase start working. So what DNA gyrase do is, DNA gyrase cut the DNA from this point So when DNA is cut from this point, it will rotate in opposite direction and it will again join the DNA. Or in simple language, it will convert the highly coiled DNA into less coiled DNA. Technically, this is known as it will introduce the negative supercoils in the DNA. In our language, we can say it will uncoil the DNA so that replication can occur. So DNA gyrase help in replication. So if we inhibit this enzyme, replication will not occur, so bacteria will not survive. The same function in humans is done by another enzyme called DNA topoisomerase. So if we inhibit DNA topoisomerase, then human cells will be killed. So that drug will be used as anti-cancer drug. So DNA gyrase inhibitors are used as antibacterial, whereas DNA topoisomerase inhibitors are used as anti-cancer drugs. Now DNA gyrase inhibitor drugs, chemically these drugs are quinolones. Quinolone is a chemical structure. Chemically these drugs are quinolones. One of the drug is nalidixic acid, whereas all other quinolones also contain fluoride atom in the chemical structure, so they are called as fluoroquinolones. Nalidixic acid and fluoroquinolones act by inhibiting DNA gyrase. Nalidixic acid is used for urinary tract infections, whereas fluoroquinolones have many uses. We need to discuss these in detail. So we are going to discuss fluoroquinolones now. Fluoroquinolones, the name of most of them end with floxacin. Examples of floxacins or fluoroquinolones are norfloxacin, ciprofloxacin, ofloxacin, pfloxacin, sparfloxacin, levofloxacin, moxifloxacin, gatifloxacin, trovafloxacin. So many floxacins are available. They act by inhibiting DNA gyrase and they are cidal drugs. They kill the bacteria. Now, special point about fluoroquinolones as a group to remember. Fluoroquinolones are effective orally. They can be given orally. And fluoroquinolones are bactericidal drugs. So they are oral cidal drugs. Most of the cidal drugs which we discussed earlier are injectable. Like penicillins are injectable, vancomycin is injectable, aminoglycosides are injectable, but fluoroquinolones can be given orally. They have wide spectrum, effective against both gram-positive as well as gram-negative bacteria. Fluoroquinolones have wide spectrum. They are effective against gram-positive organisms like Staphylococcus aureus, even MRSA they are effective, and they are effective against gram-negative bacteria including Pseudomonas. But problem is fluoroquinolones are contraindicated in pregnancy and children. They are contraindicated in pregnancy and children. The reason is they cause cartilage and tendon damage. Remember, tetracyclines were causing problem in bone and teeth, whereas fluoroquinolones cause problem in cartilage and tendon. So they are contraindicated in pregnancy and children. Next important thing to remember, fluoroquinolones can induce seizures. So they should be avoided in epileptic patients. Fluoroquinolones are avoided in epileptic patients. They can induce seizures. Then fluoroquinolones are contraindicated in renal failure. The question asked is exceptions. That means which fluoroquinolones are safe in renal failure. So you can remember, you can give PMT in renal failure. Pre-medical test can be given in renal failure. PMT is safe in renal failure, and PMT stands for pfloxacin, moxifloxacin and trovafloxacin. So P, moxi and trovafloxacin, they are safe in renal failure. Another important property of fluoroquinolones is fluoroquinolones are phototoxic. Fluoroquinolones can cause phototoxicity. The question asked is which is highest phototoxic? The answer is sparfloxacin. Sparfloxacin has highest phototoxicity. Fluoroquinolones are phototoxic. Maximum is sparfloxacin. Next important thing to remember is a term used in fluoroquinolones. It is called as respiratory fluoroquinolones. So some fluoroquinolones are called as respiratory fluoroquinolones. The examples are ofloxacin, moxifloxacin, gatifloxacin and levofloxacin. So these fluoroquinolones, they are called as respiratory fluoroquinolones. Now why they are called respiratory fluoroquinolone? Because they can kill almost any bacteria which cause respiratory tract infection. Like they can kill gram-positive bacteria causing respiratory tract infection like Staphylococcus, Streptococcus, Pneumococcus. They can kill gram-negative bacteria causing respiratory tract infection like Klebsiella, Pseudomonas, Proteus. They can even kill atypical bacteria causing respiratory tract infection like Mycoplasma, Chlamydia, etc. And they can even kill Mycobacterium tuberculosis. So basically, they can kill all the bacteria which cause respiratory tract infection. So when we come to know that they can kill all the bacteria, so suddenly we will say that, oh my God, they can kill all the bacteria. So, oh my God. So these are, oh my God, fluoroquinolones. And remember, levofloxacin is an isomer of ofloxacin. Levofloxacin is an isomer of ofloxacin, and you can remember only difference between ofloxacin and levofloxacin is levofloxacin start with L, means it is long acting. So you can simply remember levofloxacin is long acting ofloxacin. So oh my God, fluoroquinolones, they are respiratory fluoroquinolones. Now moving to important points regarding the individual fluoroquinolones. The first one, that is norfloxacin. Norfloxacin is mainly excreted by kidney. So when we give norfloxacin, it is concentrated in the kidney, in the urine. So it is used for urinary tract infections. Norfloxacin is used for UTI. Apart from this, norfloxacin, it has lowest oral bioavailability. Among all the fluoroquinolones, the minimum bioavailability is present with norfloxacin. On the other hand, the maximum oral bioavailability, it is present with levofloxacin. So norfloxacin has lowest, whereas levofloxacin has highest oral bioavailability. The another fluoroquinolone called ciprofloxacin. Special point to remember about ciprofloxacin is ciprofloxacin, it has become now the drug of choice for prophylaxis of meningococcal meningitis. We discussed already in the meningitis section. Ciprofloxacin is a drug of choice for meningococcal meningitis prophylaxis now, but it is contraindicated in pregnancy and children. Second, ciprofloxacin is also co-drug of choice in anthrax. For anthrax, we have two main drugs which are first line drugs. One is penicillin G and second is ciprofloxacin. Penicillin G is overall drug of choice, but ciprofloxacin is also the first line drug for anthrax. Third important use of ciprofloxacin is enteric fever. Ciprofloxacin is first line drug in enteric fever also, but nowadays more commonly used are third generation cephalosporins like ceftriaxone. Clear? The next important fluoroquinolone is sparfloxacin. We already discussed sparfloxacin. S par, sun के पार नहीं जाने देती. It is most phototoxic fluoroquinolone. Among the fluoroquinolones, maximum phototoxicity is caused by sparfloxacin. Apart from this, sparfloxacin is the longest acting fluoroquinolone. But problem is, although it is longest acting, but the question which is asked, which of the following is longest acting fluoroquinolone, sparfloxacin is mostly not in the options, because we rarely use sparfloxacin due to risk of phototoxicity. So options do not contain sparfloxacin. So you need to know after sparfloxacin which is the longest acting fluoroquinolone. So second longest acting fluoroquinolone is moxifloxacin. If sparfloxacin is not in the option, then the answer you should mark as moxifloxacin as longest acting fluoroquinolone. So sparfloxacin is longest acting. Next longest acting is moxifloxacin. Clear? Then this getafloxacin, you can remember G for getafloxacin, G for glucose. Getafloxacin can affect the blood glucose. It causes dysglycemia. In some people, it can lead to hyperglycemia. In some people, it can lead to hypoglycemia. So due to this side effect of dysglycemia, getafloxacin has already been withdrawn from India. Okay. Then the last fluoroquinolone is moxifloxacin. Most important fluoroquinolone. We have already discussed several points about moxifloxacin. We just discussed it is the second longest acting fluoroquinolone. So if fluoroquinolones, sparfloxacin is not in the option, then answer will be moxifloxacin. Second, moxifloxacin is one of the PMT drugs. Remember, safe in renal failure. So pfloxacin, moxifloxacin, trovafloxacin, safe in renal failure. Third, it is one of the oh my god drugs also. Means it is a respiratory fluoroquinolone, widest spectrum, used for so many infections. Apart from that, moxifloxacin is also effective against anaerobic bacteria, effective against anaerobes also. So these are the important points regarding the fluoroquinolones. So now we will move to the last mechanism, that is drugs affecting cell membrane. The important drugs affecting cell membranes are daptomycin, polymyxin B, and polymyxin E. The other name of polymyxin E is colistin. These drugs act on cell membranes, starting with the daptomycin. Daptomycin, it is used for VRSA. Daptomycin is a drug of choice for infections caused by vancomycin-resistant Staph aureus. But the problem is, daptomycin, it becomes inactivated by surfactant present in the lungs. So it is not effective in infections of lung like pneumonia. So vancomycin resistant Staph aureus infections, drug of choice is daptomycin, but not for pneumonia. It is not used for pneumonia. So if the VRSA is causing pneumonia, then the drug of choice is linezolide. So daptomycin is a drug of choice for infections caused by VRSA except pneumonia, where the drug of choice is linezolide, because daptomycin become inactive by pulmonary surfactant. Then the major side effect of daptomycin is myopathy. Daptomycin can result in myopathy. Clear? Then polymyxins, so P for polymyxin B, P for polymyxin E, P for pseudomonas. So polymyxins, they are effective against pseudomonas infection. So mainly they are used for gram-negative infections, including pseudomonas. Colistin in particular, the question is asked, colistin, it is effective against even metallo-beta-lactamase producing bacteria. Remember we discussed about superbug, the bacteria producing New Delhi metallo-beta-lactamase. Colistin is effective against those bacteria also, but colistin is not effective against Serratia and Proteus. So most of the gram-negative bacteria colistin can kill, but is not not effective against Serratia and Proteus. Clear? So these are the important points about the different mechanism of antimicrobial drugs. Okay.